Good morning. We're just going to go ahead and continue again with the receptors that we were talking about that send signals to the brain. We have receptors within our blood vessels and our body that tells us what our pH is. Also, they tell us what our amount of oxygen and the amount of carbon dioxide within the blood itself. So we'll continue with that one. Remember that large amounts of carbon dioxide will actually trigger you to breathe. You also have a low amount of oxygen that will actually also have you trigger to breathe. So now we have also pH receptors that also help you in respirations. Now the lungs themselves have what they call they have lung receptors, and there's three types. There's irritant receptors, stretch receptors, and J receptors. I think I mentioned yesterday about the J receptor on how, I had a patient that his lungs were filling up with fluid, and it got to the point where the J receptor got triggered and he just started hyperventilating. And I remember I told you that the PA that I was with was trying to tell him to calm down, and there's no way you can calm this person down unless you remove the fluid that is actually being built up within his lungs. So then irritant receptors also will cause us to actually cough or sneeze. And then we have the stretch receptors that allows us to stop from inhaling or inhaling in. So if you try to inhale as much as possible as you can right now, there's only going to be a certain amount that you can actually inhale, only for the simple reason that the stretch receptors will not allow you to inhale anymore. So regular ventilation with the respiratory centers in the brain, you have ventral respiration group, the dorsal respiratory group, and the pontine respiratory center also. We'll talk about ventilation perfusion ratio. Ventilation perfusion ratio is the relationship between alveolar ventilation and perfusion of the alveolar capillaries. So what it's trying to tell you, this slide's trying to tell you, is that the amount of oxygen that goes into the alveoli is going to help diffuse that oxygen that's in higher concentrations in the alveoli into the capillary beds. So this can actually can be used to explain causes like hypoxemia. So, and I gave you the example yesterday. If you throw yourself in a swimming pool, you get underwater, how much oxygen do you receive?
None.
None, correct. So if you don't have any oxygen in your alveoli, you cannot transpose that through diffusion into the capillaries. So, I mean, it's kind of an example, but if for whatever reason you get an obstructed airway, then the same thing happens. There's no oxygen going into your alveoli. And if you don't have a high concentration of oxygen in your alveoli, you cannot diffuse that into the capillaries. Remember, diffusion goes from an area of higher concentration to an area of lower concentration. So this slide shows you how actually within this section here, you have high concentrations of O2. I'm sorry, right here, O2, which basically diffuse into the capillary. But then you have blood that's returning back to the venous system that has higher concentrations of CO2, which basically diffuse this way. Same thing happens in the tissues. The tissues are there to where they utilize the oxygen that they received from the red blood cells, and they return CO2. And the CO2 will basically has higher concentrations of CO2 in the cell, lower in the bloodstream, and now the bloodstream itself is going to receive deoxygenated blood. Okay, ventilation perfusion ratio. It's an ideal state, and the amount of ventilation is equally matched to the amount of perfusion. However, a perfect match does not actually exist. Overall, perfusion exceeds ventilation, but the situation is highly functional. So it works. That's what it's trying to tell you. that it works no matter what. Since we only have 21% in ambient there, it works, and it works better if we have 100%. When a ventilation is better than perfusion, there is a wasted ventilation. So let's say you breathe a lot faster, but if you don't have any oxygen going in, then it's just wasted ventilations. And when the perfusion is better than ventilation, where it actually sucks in, the oxygen, it's a wasted perfusion. And you get to see this example right here of what possible causes can actually cause that. So in normal ventilation perfusion, you have the alveolar right here having a good amount of oxygen and basically releasing that oxygen, oxygenated blood, to the oxygenated blood in the alveoli, and the carbon dioxide that's coming in is actually releasing it into the to this, so you can actually breathe it out. Now, in cases where you have a plug, like this shows right here, and air goes trying to get in, but it doesn't, so then you don't have a high concentration of O2 here. Okay, it's a very low concentration, and the blood stays unoxygenated because there's no oxygen-rich blood here. I mean, oxygen-rich environment here to transfuse or diffuse this O2 into the capillary bed. In this other situation that you see here, which is a third example, you get to see that there is actually oxygen going into the alveoli, high concentrations, but the returning capillary has a clot, okay? And this clot prevents any blood from going in there. So if you don't have blood going in there, there's no oxygenation of that blood. So that would be the perfusion section. Got it? Okay. And pressure imbalance, and the air pressure in an alveolus exceeds the blood pressure of the capillary bed, blood flow through the capillary stops. This usually occurs normally in the apex of the lungs, and then occurs when the systemic blood pressure decreases also. So your systemic blood pressure, which is the amount of blood, sorry, the dogs are barking, that actually, it occurs when the systemic blood pressure actually decreases, and this is the amount of blood that's actually trying to return. It's not there, so it doesn't have any perfusion. Now, ventilatory disturbances, a condition that it decreases the amount of air reaching the alveoli, such as asthma, results in wasted perfusion. You have hypoxemia. What is hypoxemia by definition? Hypoxemia.
Low oxygen.
No, well, hypoxemia, remember, hypo means low, oxia means oxygen. So hypoxemia is low oxygen. Okay, so a condition that decreases the amount of air reaching the alveoli, such as asthma, which basically when asthma, you have a diminished lumen of the bronchioles. You have wasted perfusion because you have hypoxemia, and hypoxemia and hypoxia results, which basically it's kind of the same thing. One of them is the factor and the other one is the result. Treatment is aimed to increasing the lung ventilation themselves. So what we do is we give them, let's see if you have a lumen of the bronchioles that's supposed to be this big, but because of inflammation and everything, the lumen now becomes this big, and all this is inflammatory tissue. Not only that, the production of mucus plugs and everything. Then what we do is we need to give a medication that will increase the lumen of that bronchiole. So we give them something like Ventolin, we give them something like albuterol, that will actually cause the bronchioles to actually become bigger, and air can actually go through. So medication that's actually inhaled, some of them may actually be injected into the bloodstream that actually acts on the adrenergic receptors, alpha 1, alpha 2, beta 1, beta 2, to actually cause an increase in the size of this. So now you can actually breathe a lot better. So that would be the treatment. And then not only that, we also give oxygen to increase the oxygen placement that's within the alveoli. Ventilation is, perfusion disturbances when the ventilation is normal or even increased, but blood flow through the lungs is decreased, like when we have a plug or a blood clot that's stopping it. This results in wasted ventilation, so you can breathe as much as you can, but no oxygen can actually get into the bloodstream. This is leading to a hypoxemia or hypoxia. Administration of oxygen may help, but the perfusion disturbance must be corrected. So you have to think about, in this type of situation, you might actually have one of the terminal bronchioles that leads to the alveoli. Okay, working fine. So you get basically oxygen going in there. But the capillaries themselves that are surrounding it, you might actually have a clot in one of the capillaries. Now, key thing, if you give them oxygen, it'll help. For the simple reason that not all the alveoli, the capillary beds in the alveoli are being constricted or unperfused. So what happens at this point is that you have blood going in the regular ones, but the one that's clotted is not. So eventually, once you give them higher concentrations of oxygen, you might actually get better results, as opposed to that one single one might not actually be able to transfuse. Now, there's enough of them that get affected in the lung because you have a bigger clot, then we have to worry about it. It's basically what we call shunting when it comes to medical terms. Okay, now transport of O2 and CO2 by the blood. Oxygen must be continuously delivered by the blood to the cells. Okay, carbon dioxide must be carried back to the lungs and be blown off during exhalation. A disturbance in the transport of the system may actually lead to cellular hypoxia or hypercarbia. What does the word hypoxia mean to you? You guys hear that? It's a dog drinking. Shh. Okay, so basically, let me see. The word hypoxia means low oxygen, right? You're correct. What is hypercarbia? Well, hyper, you know what the word hyper means, right? Above normal?
Fast.
Yeah, fast. What is carbia? What do you think carbia means? Okay, we're dealing with the pulmonary.
Carbon.
Okay, and what?
Oxygen.
And okay, what is that one called?
Carbon dioxide.
Carbon dioxide. Hypercarbia is increased numbers of carbon dioxide. And normally, and I want you to think about this, normally we have that seesaw effect. So let's say we draw a seesaw right here. Okay. Let's make it better. Okay. So you have high amounts of O2. The amounts of CO2 are going to be low. And then the opposite also, when you have large amounts of CO2, the O2 levels are going to be low. Okay? Now, sometimes there's a mismatch in this where you might actually have high amounts of CO2 that do not get released, but you still get an amount of oxygen going in there. But that's very rare and seldom. But normally, when you have high amounts of O2, you have low amounts of CO2. This usually happens within the transport of O2 and CO2 by the blood, and this usually in the lungs, in the lung tissue itself. Okay, at this point, we have the lung tissue itself, where basically you have blood receiving oxygen from the alveoli and releasing CO2 into the alveoli so you can breathe it out. And they also have this in the cellular level, where you have now the oxygen-rich blood releasing it oxygen to the tissues, and the tissues are releasing CO2 back into the blood. Okay. Oxygen transport, O2 is transported in the blood in two different ways. 1.5 to 3% is dissolved in plasma. Now, have you all ever seen a pulse oximeter?
Are those the little clips that you put on your fingers to check? No.
Yeah, that's what it
No,
is. A pulse oximeter is a little device that you put on your fingers. Sometimes they put on your earlobe, sometimes they put on your skin. So you can actually determine the amount of oxygen that's within plasma. Anything about 95% is considered normal. So 95% and above, you're okay. Once you start hitting 94% and go down, then we need to forcibly give you oxygen. But 95 and above is normal. And that's what the pulse oximeter is checking is the oxygen concentration within your plasma. Now, does this mean you're having good perfusion? Yes or no?
Yes.
Okay, yeah. But ideally, yes. But remember, when we put that pulse oximeter, let's say we put it on the finger itself, that's not telling me how much oxygen my heart is getting. It's just telling me how much oxygen my nail or my finger is getting. So if you look at a person and their pulse oximeter is 95 and above, but then you see him cyanotic, which is kind of a bluish color, then you know that that might not be a correct. Now, there's certain cases, and you're gonna get to see this in your exams, where you actually have a person there that is cherry red in color. Okay, and because they're kind of cherry red in color, you think they might be oxygenated correctly. But then they tell you the other signs and symptoms that they've had, that well, it was a group of people within a house, and they all started feeling sick around the same time, flu-like symptoms, vomiting, and then you find out that there's the person has a furnace, which is not a common thing that we have here down the valley. It doesn't get cold enough for us to actually buy furnaces. But furnaces is basically a heater, a gas control heater that is within the house. And that one might actually release carbon monoxide. Now, carbon monoxide, which is CO, has a higher affinity to attach itself to a red blood cell than O2.
So that's what comes out of the mufflers, right, of the car?
Yeah. The problem is with this one, it will stick to the red blood cells a lot better than O2. So it will throw off whatever O2. But since it's an oxygen molecule within this, it will not give you the bluish coloration. It will give you a
Reddish, pink.
like a reddish, higher red coloration. And that's basically a carbon monoxide poisoning. And you're gonna get to see this, a lot, in the questions. Which I don't think it's fair for South Texas, but then again, just know that a group of people getting sick at the same time, showing color red, and they have altered mental status, consider them that they might actually be suffering from carbon monoxide poisoning until you prove otherwise. So then we have 1.5 to 3% carried in plasma. Then we have 97% to 98.5% carried in hemoglobin. And hemoglobin has to have what in order for you to actually carry blood?
Iron.
Iron, there you go. Now, oxygen transport, the role of hemoglobin, this is a protein molecule that contains iron. Okay, there are 4 iron sites per hemoglobin. So if there are 4 iron sites per hemoglobin, that means that each hemoglobin molecule is going to carry 4 oxygen molecules. And remember, you have to multiply that by the millions of hemoglobin molecules that we have within the red blood cell. So we do have a capacity of carrying a lot of oxygen until something happens. Now, carbon dioxide is transported in the blood in 3 different ways. We talked about oxygen transportation, now we're talking about carbon dioxide transportation. In this one, 7% is dissolved in plasma. 23% is only attached to hemoglobin. Remember in the other one, it was what? 70, was it like 80 something percent? Now it's only 23%. What do you think only 3% is actually carried in the red blood cells? But don't red blood cells have to carry oxygen? And if that takes a large amount of oxygen, hemoglobin molecules, then you carry a lot of oxygen. You don't have that much space for CO2, so only 23%. Now, 70% is transported by the lungs in the form of bicarbonate. Where do you have carbon monoxide and oxygen exchange in the body? Where do you replenish the carbon dioxide and oxygen?
Capillaries.
Yeah,
Capillary beds.
in the capillaries, but where? What capillaries?
lungs.
Yeah, in the lungs. That's where you get it. So that's why it's telling you that 70% of the transport is transported by the lungs. Well, that's where the carbon dioxide exchanges with O2 and it leaves through the respiratory tract. That's why it's telling you that. And then we show again the same thing where we actually have interchange of oxygen and carbon dioxide. It's attached to hemoglobin and dissolved in plasma. Carbon dioxide is transported by the blood 3 different ways: by bicarbonate, attached to hemoglobin, and dissolved plasma. And remember that we went over that little calculation, or that little, it wasn't a calculation, I'm sorry. It was a reaction, chemical reaction, where the byproduct of cellular metabolism is water. What's an ugly O? Okay, plus CO2. Remember that yesterday? Now this combines itself to become the buffer, to work in the buffer system by developing H2C.
Water.
Oh, no.
Oh,
No.
that's hydrocarbonic acid.
Carbonic acid, there you go. CO3. And then this carbonic acid then goes one way and it loses a hydrogen, okay? And you have a buffer, which is HCO3, which is basically, what's HCO3? Bicarbonate, like baking soda, bicarbonate. So now, hold on, give me a few seconds. People decide to text me when I'm teaching. Okay, so basically you lose a hydrogen, which now the hydrogen can combine with OHs and become water. So this chemical reaction goes both ways. It can become bicarbonate and go back to carbonic acid and then break down into this, water and CO2. So let me see. Alveolar capillary gas exchange. After inhalation, the alveoli air is high in O2 and low in CO2. The venous blood in the capillaries surrounding the alveoli is low in O2 and high in CO2. So because of this concentration gradient that we have here, we have the exchange of oxygen from an area of higher concentration to an area of lower concentration. And we also have the exchange of carbon dioxide from an area of higher concentration to an area of lower concentration. So let me ask you this question. Okay, in which mechanism does most of the oxygen in the blood is actually transported? Oxygen in blood. Is it bound to hemoglobin in the form of bicarbonate and dissolved plasma, or carried by white blood cells? Well, you know white blood cells is not going to be the one because white blood cells don't carry oxygen. So which one is it?
Isn't it A?
How many say A?
Me.
Okay,
Me.
just one?
So about
Two?
two.
It's actually A because remember, hemoglobin carries oxygen, large amounts of oxygen. Then bicarbonate is basically the way we kind of we get rid of waste products, but it doesn't carry oxygen. It's usually in hemoglobin. Blood volume. A determinant of blood pressure is perfusion and its blood volume. Adults have about 70 mLs of blood per kilogram, or per kilogram of body weight. And usually you have an adult that's 70 kilograms, which is about 130, 140 pounds, usually has 49 million mLs of blood, or 4.9 liters of blood, which usually it's what they usually read in most biology books. Everybody, human beings have about 5 liters of blood. So I know I scared one of my patients once because I always had a hard time with kilograms and pounds or whatever, right? I just remember that if you have 70 kilograms, you double it up, that gives you the pounds, right? So 70 kilograms might be equal close to about 140 pounds. But I had this patient that was a diabetic, and I told her, you know, if you lose 20 pounds, you might actually control your sugar. So lose 20 pounds within about a month, and then we'll check you again. So she turns around and said, well, how much is 20 pounds? So I told her, and for whatever reason, I doubled it up. Oh, it's 40 kilograms, which I did the opposite. And she got freaked. You want me to, so I was telling her to lose 80 pounds in 1 month. And she just got freaked until, thank God for the nurses, She turned around and said, oh, no, this is the way you do it. Oh, okay. So anyway, so blood composition, in other words, what is in blood? 45% is formed elements. Have y'all ever done that experiment, somewhere in biology, or seen the picture in your books? Because I know that even the EMT book, once you get it, is going to have the picture. You're going to have a test tube. And I know what we used to do, because they would allow us to do a lot of stuff. We have a test tube, we'll fill it up with blood. Let's get to about right here. And we wait about an hour, and through gravity, the solid components of it would settle down at the bottom. Then you would have an area of clear fluid that would be your plasma. A lot of times mainly it's all plasma, but if you decide to eat a burrito for breakfast, then you have a section in here that's basically fat, and will form at the very top. So this would be your red blood cells, your white blood cells, and your platelets. I ran out of play. So this area right here is your red blood cells, white blood cells, and platelets. This area right here would be your plasma. Okay, so you have, this area would be the fat content if you have any. And it depends on what you eat. So it separates, and that's what it means. 45% is formed elements. The formed elements would be this right here. And then the 55% would be plasma, which would be this section right here. You never seen that picture, guys? In your textbooks, even biology, anatomy?
Yeah.
Yeah. I mean, it's in most books, so, and that's what it means that, once you separate them, that's what it is. Now, blood distribution, the majority of the blood is in the venous system, and the minority of the blood is in the arterial system. Now, blood is distributed in the venous system, various components, of the cardiovascular system, and it follows the veins about 64%, the arterial system about 13%, pulmonary vessels about 9%, capillaries about 7%, and the heart carries about 7%. Now we're gonna go over what actually transports fluid within the lung, within the blood vessels. And one of the ones that we deal with is hydrostatic fluid. Okay. Hydrostatic pressure. This is force inside the vessels of capillary beds that is usually greater by the contraction of the heart and the blood flow. So in other words, let's say your ventricles contract. And once your ventricles contract, let me draw this way. The ventricles contract, you have the amount of pressure that's right here being giving you your systolic blood pressure that might be able to actually, especially in the smaller blood vessels, seep out some fluid, some blood into the interstitial area. Okay, and the lack of it would be your diastolic. So the force inside the vessels of the capillary beds is greater than the amount. So if this is greater than the amount, then you're gonna have some hydrostatic pressure releasing fluid into the interstitial area. Hydrostatic pressure also exerts a push inside the vessels of the capillaries, which basically is the same thing. Now, the good thing is that we ourselves in the human body have something to maintain the fluid inside the blood vessels. And then basically we have sodium. We also have a little bit of potassium. And that basically a higher concentration is, I've always learned that. I've always known that water is going to follow salt. So if you have sodium inside the blood vessel, higher concentration here than out over here, then it'll suck some of the fluid from the interstitial into the blood vessel. And sometimes it just stays there. Now, the key thing is that, we have a fluid that we can actually give patients that is called normal saline. Have you all ever heard of the normal saline fluid? I think I mentioned it before, but if you have a person, let's say this is the arm. Okay? And you give a 1 liter bag of fluid, an IV into the arm, you're gonna maintain blood pressure, okay, by increasing the amount of fluid in there. But the only thing is that there's a 1-to-3 ratio that will last within an hour. So for every 1 liter of blood that you lose, you have to replace 3 liters of normal saline. Okay, and you're gonna see this question. You're gonna see this question because it's expected to be known by EMTs and everybody in the medical field. So you have a 1-to-3 ratio. We actually have to force fluid in there. Now, the other thing we can do is we can actually change the tonicity, in other words, the amount of salt and the amount of sodium in here. So if we have something that has greater amount of salt, then once it gets to the blood vessel, blood is going to be sucked out automatically from the interstitial fluid. But the thing is, it is also sucked out of organs and everything else. If we have a lower amount, then we have blood coming in here, and there's a higher tonicity outside, so blood's going to seep out. So it just depends on what you ordered or you want to do. Did that make sense to you guys?
Yes, sir.
Okay. Now, blood volume, we have plasma or oncotic pressure. Now, oncotic pressure is different from hydrostatic pressure. The oncotic pressure keeps fluids inside the blood vessels to oppose hydrostatic pressure, and it usually uses sodium and all this other good stuff. The large plasma proteins, and I think one of them that we use is albumin, also attracts a lot of fluids. So basically, if you have an albumin type of situation in the bloodstream, it's going to attract a lot of fluids within the blood vessel. So it's going to steal it from the interstitial space. And then we have this diagram shows how actually oncotic pressure, you have an increase of blood, you have an increase of pressure inside the capillary, it releases O2. But you have a decreased amount, then it pushes it back in. Okay, the myocardium must also, the pump function of the myocardium must also be effective pump to actually maintain perfusion. So we have a term called cardiac output. And cardiac output is the amount of blood that's ejected from the heart in 1 minute, okay? And cardiac output, basically the force of the contraction, and it deals with force of contraction and the heart rate, how fast your heart's going. So cardiac output equals to heart rate times stroke volume. Give me a few seconds, guys. I need to do something. Okay, so basically cardiac output equals the heart rate, which is how many beats per minute the heart's going to go, and the stroke volume, which is the contractile force of the heart itself. The myocardium must be an effective pump to actually maintain perfusion. So heart rate is controlled by the sympathetic nervous system, and it's also controlled by the parasympathetic nervous system. The sympathetic nervous system, when it comes to heart rate, is going to cause it to increase. So the sympathetic nervous system is going to cause it to increase. And normally we release adrenaline, also known as epinephrine, within our system to increase heart rate. Now the parasympathetic slows it down. Okay. Okay, the myocardium must be an effective pump to maintain maintain perfusion. Now, by definition, what is perfusion? What is perfusion? Don't fall asleep. Definition of perfusion. Thank you, sir. Perfusion, because I know the answer, but I'm not getting tested over this. Perfusion basically is perfusion is the amount of oxygen-rich blood that reaches the that reaches the target organs or the target cells. Okay, and it's controlled by the contractile force and the blood pressure. So you have a decent blood pressure, then you have good perfusion. And all this, basically the perfusion is actually defined by stroke volume. And the stroke volume is, you have to worry about preload. And I'm gonna draw you the heart like in Valentine's Day. Preload is the amount of blood that's actually coming back in. Okay, remember we have 4 different chambers. Coming back into the atrius, and then basically contractility is the amount of force the ventricles contract, and afterload is the amount of blood that's actually going against peripheral vascular resistance. So in this diagram, what you see in normal preload, you have a normal amount of blood coming in, and the contractile force actually causes the blood to actually come out. So this would be the normal volume. But if you have a reduced preload, in other words, the amount of blood that's coming back into the atrius, then you're going to have a smaller amount of blood going into the ventricles, and you're going to have a smaller amount or lower volume of blood coming out. Does that make sense to you guys?
Yes.
It's like cash flow. If you're not working, you don't have any cash coming in, so you cannot spend anything. But when you're working, you have money so you can spend. I mean, I don't know. That's due to coronavirus. Then the contractile force is basically you have a normal contractility, which basically you have a normal amount of blood coming in, but when you contract, this is denoted by the large arrows here, contract this ventricle, it will have a normal amount of volume. But for whatever reason, if you see, which is reduced contractile force or contractility, it has smaller, which is denoted by smaller arrows here. You don't have that much coming out, but you don't have that much blood coming out. You still have a normal, the normal volume coming into the ventricle, but you don't have as much blood going out because it's not pushing it out as fast. Now, this is based on a couple of other things, and we'll go over the other reasons too later on in this lecture. So, the factors that increase cardiac output. And what can actually increase the, for you to actually get a normal or above normal blood coming out of your heart? Well, you increase the heart rate. If you rev up the engine, then basically you increase the cardiac output. You increase blood volume. So if you give more blood, if you make more blood or infuse more fluid, then you increase cardiac output too. Increase myocardial contractility. If you give a medication that causes the heart to pump stronger, then that stronger contraction will actually increase cardiac output. The sympathetic nervous system stimulation. If you stimulate the sympathetic nervous system, it's going to release chemicals that are going to work on certain receptors, which is going to increase heart rate, which is going to increase cardiac output. Beta-1 stimulation from epinephrine, which is what I just talked about. And if you lower diastolic blood pressure. Now, if I lower diastolic blood pressure, what does that mean? So let's see, remember that drawing that I had, and I put it in a little bit. So you have your blood vessel with a gulp of blood that the ventricle just squeezed out. This pressure right here, up and down, is what gives you your systolic blood pressure. Okay. So it gives you systolic. And whatever's left behind that keeps the vein open after the contractile, notice when the ventricles relax, it gives you your diastolic. Okay, so if you lower your diastolic blood pressure, in other words, if I lower this, so let's say we have a blood pressure of 140 over 100. The top number is going to be your systolic blood pressure. That's the pressure that's being put against the blood vessels, right? The lower number is going to be the amount of pressure that's being put against the blood vessels once your ventricles relax. So the thing is that if you want to go ahead and increase the amount or increase the amount of cardiac output, you lower this and you make this a little bit more easily, it's larger, so you can actually allow more blood in there. You understand that concept?
Yeah.
Okay, so more, you're gonna increase it by, because the more blood that goes through, the more blood that can actually come back to actually get recycled. Now, factors that decrease cardiac output. We just talked about the ones that increase it, not the ones that actually bring it down. Is if you lower your heart rate, if you lower your blood volume. In other words, if you lower the heart rate, it'll bring down the cardiac output. If you decrease the blood volume, in other words, if you're bleeding out, you're going to lose your blood pressure. If your heart is not pumping as good as it's supposed to, it's going to also decrease cardiac output. If the parasympathetic nervous system kicks in, remember the other one's a sympathetic, and if this one is the parasympathetic nervous system kicks in, then you're going to have a lower cardiac output. Now, we had beta 1's receptor, basically receptor stimulation caused an increase, but if you have a blockade of the beta 1 receptors by using beta blockers, then you're going to decrease cardiac output. And you have higher diastolic blood pressure over time, it will decrease also the cardiac output. Now, in this one, I know that, when we talk about patients that have hypertension, have high blood pressure, we sometimes give them what we call a beta 1 blocker to actually decrease their blood pressure. So by decreasing cardiac output, you also decrease that also. Systemic vascular resistance, also known as SVR. The systemic vascular resistance is the resistance of blood flow through the vessels. So in other words, the same drawing that I had is if your blood vessel itself is this white as opposed to this white. Okay, so systemic vascular resistance is the resistance of blood flow through a blood vessel. Vasoconstriction, which will be in this one where you constrict the blood vessel, increases systemic vascular resistance, which basically increases blood pressure. So isn't it true that if I make this a lot smaller, wouldn't the blood pressure be higher in this one than in this one? Yes, no, maybe so. Yes, sir. What, sir? Thank you for the answer, guys. Okay, vasodilation, if you open up the blood vessels, like maybe this big, you have a decrease in systemic vascular resistance, which actually decreases blood pressure. And here you have a diagram on vessel, a condition is vasoconstriction, which is decreases it, which gives you higher blood pressure, as opposed to vasodilation, which opens it up. That was not right. Vasodilation actually increases the size of the lumen of the blood vessel, which decreases blood pressure. Now, systemic vascular resistance affects blood pressure or pulse pressure. Now, by definition, what is pulse pressure? It tells you here the difference between the systolic and the diastolic reading. Now, it's important to know this for a couple of reasons. Well, one of them, we're gonna be coming up when we start doing that. Let me see. That basically, you have a blood pressure of 140 over 80. So this would be the difference between 140 minus 80. What is that? What is 140? Don't get your calculators out. Or get your calculators out. What's 140 minus 80?
60.
60. Okay, now you take another blood pressure and you end up with 130 over 90. What is the pulse pressure there? What's the difference?
40.
40. Okay. Let's put that right here. Now, if you have a the third blood pressure you take is 120 over 100. What is that? What's the difference between there?
20.
20. So you notice one thing, that the difference between the pulse pressures gives you, the difference between the blood pressure, the systolic and diastolic, gives you the pulse pressure. And we can use this to diagnose a couple of conditions. One of them is pericardial tamponade. So pericardial tamponade is a condition where you have the heart itself. Well, I'm going to draw the heart simple like this, right? And then you have a tissue that surrounds the heart, a fibrous tissue. Is called the pericardium. Okay, the pericardium is not easily stretched. It is very tough. So what happens is that, let's say if you get stabbed by a knife in the next part of your heart, you start spewing out blood into this region right here, between the pericardium and the heart. Now, the more pumping action that your heart has, the more you're going to be pumping blood into this tissue. And you start filling this tissue, now you have the pericardium the same size, but the heart gets compressed a lot more. So one thing that you're going to be able to determine is, if you take 3 blood pressures, this will be the first one, and this will be the second one, this will be the third one. If you notice a decrease in pulse pressure, if the pulse pressure gets smaller, then it's a good chance that they might actually have pericardial tamponade. The other one is, you get your stethoscope. And your stethoscope, you put it in your ears and you put it on the person where the heart's supposed to be at, not on yours, on the patient's heart, and you hear it muffled. Instead of lub-dub, 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 you hear like it's muffled, like there's somebody put a pillow on top of it. So if you have those two, then you know that they're actually going to pericardial tamponade. You also, you have to think about it too. If this guy is driving, this is mainly caused by trauma. If this guy is driving his truck and he decides to plow into a utility pole, okay, and the emblem of the Ford that was in the steering wheel now is tattooed on his chest, that means his chest hit the steering wheel very hard. And sometimes blood vessels rupture and cause pericardial tamponade. So would you be able to diagnose pericardial tamponade now? You can use it by looking at the pulse pressures and by looking at hearing the muffled heart sounds. So one step closer to becoming an EMT. So basically, the pulse pressure is the difference between the systolic and diastolic. Systolic blood pressure is rough indicator of cardiac output, and the diastolic blood pressure is rough indicator of systemic vascular resistance. So remember, in that little magical ball, well, not magical, but let's say your ventricles contract. Your ventricles contract, and it sends out a gulp of blood within your blood vessel. Okay, this here, okay, is basically a rough indicator of the systolic blood pressure, which is there. It's a rough indicator of cardiac output. In the diastolic, where it's basically after that ball goes through and whatever it keeps these blood vessels open, is actually an indicator of systemic vascular resistance. So myocirculation or microcirculation, I'm sorry, refers to the blood flow through the arterioles, capillaries, and venules. So at this point, microcirculation is a blood flow through the smallest blood vessels, arterioles, and capillaries, and venules. And this precapillary sphincters, which are basically little muscles located right here, okay, can actually close up. So have y'all ever gone, and I know that's kind of a weird question to ask, in the outside when it's very cold? Anybody? Well,
What was the question here?
the question is have you ever gone out on a cold day, a very, very cold day?
Yes, sir.
Sometimes your fingers turn pale, sometimes they turn blue. And this is all because of this shunt right here, this precapillary, the sphincter itself is closing it off. So what happens now, the capillaries are very superficial. So what happens is if you go out and the normal body temperature that you have is 98.6, and you go to a cold environment and you're not wearing your gloves, then your fingers start getting cold. And when your fingers start getting cold, the blood that is traveling to your fingers cools down also. So now it's going back to your system, kind of cool down, and the body doesn't like that. It wants it at 98.6. So when this happens, the blood supply gets shunted off from the peripheries, through capillaries. So there's no oxygen and carbon dioxide exchange, and it kind of turned a little bit pale or purple or bluish. Okay. Now, your normal reaction at this point, when your temperature goes down, is to start shivering. And shivering is a mechanism that the body has to increase muscle contractions to increase temperature. Sometimes you shiver so much you can't even talk. Okay. We have precapillary sphincters. Regulatory influences on the sphincters are local factors like temperature. So local factors would be the temperature. Neural factors would be your nervous system, controlling the size of your diameter of the sphincters, or the capillaries. And hormonal factors would be another one. So 3 different mechanisms to actually control those sphincters is by local factors, which is temperature, whatsoever, and then neural factors, which is basically nerve impulses, and then hormonal factors. Blood pressure. Blood pressure is equal to cardiac output plus, what's SVR stand for? Systemic vascular resistance. Okay, so the relationship of the systemic vascular and the heart rate is cardiac output. So real simple, and it's going to make sense to you because, well, you've been learning all this material. If you increase the systemic vascular resistance, it increases the cardiac output, because the more blood you bring in, the more you can pump out. If you decrease this, and if you decrease the amount of blood coming back in, then your cardiac output is going to be decreased. If you increase the heart rate, it's the amount of times that heart pumps per minute, then you're going to increase the cardiac output. If you decrease the heart rate, then you can actually decrease the cardiac output. Do you guys understand that?
Yes,
Okay.
sir.
Okay. Now, if you increase cardiac output, it will increase blood pressure. If you decrease cardiac output, it will decrease blood pressure. So if you decrease the amount of blood that's going out of your ventricles to the system, you're going to decrease it. If you increase the cardiac output, in other words, you increase the amount of blood that's going into the circulation, then you increase blood pressure. If you increase systemic vascular resistance, in which you constrict the blood vessels, you increase blood pressure. If you decrease cerebrovascular resistance, you actually decrease blood pressure. And that's actually going to be shown by the diameter of the blood vessel. So let's see in this one. So if you increase cerebrovascular resistance, a blood vessel but being this big, you make it this big, you increase vascular resistance, then blood pressure goes up. If you decrease it, you make the blood vessel this big, then blood pressure goes down. Excuse me, blood pressure. The general effect of blood pressure on perfusion is increased blood pressure, increases cellular perfusion. So if you have a blood pressure that's good, it's going to go all the way out to all the cells of your tissues, with the brain, the kidneys, the muscles, and everything, right? And if you decrease the blood pressure, you might not get that cellular perfusion. So regulation of blood pressure. We have baroreceptors within our blood vessels. Baroreceptors basically means pressure sensing receptors. Like, have you all ever heard a weatherman talking about a barometer, or the barometer is going down, where the pressure of the place is actually going down? You know, so it might actually cause an increase in rain or whatsoever, right? So baroreceptors located in the aortic arch and the carotid sinuses detect changes in the blood pressure. Then the signals are sent to the vasomotor and cardioregulatory centers in the brain. To either vasomotor, it constricts the blood vessels or dilates them, or it increases heart rate in the cardioregulatory centers. It increases contractile force and heart rate, or it decreases contractile force and heart rate, or heart rate. And then here we have a picture of how, you know, the baroreceptors actually signal the brain to send stimulation to through the vagus nerve to the sinoatrial node here through neural response, and increases heart rate. Then you also have, you know, certain hormones that are released that do the same thing. Blood pressure. Irregulation of blood pressure by chemoreceptors. A decrease in blood oxygen levels stimulates a sympathetic nervous system. So when your blood oxygen levels go down, it increases the sympathetic nervous system to increase the heart rate. Our heart rate increases and the blood pressure and the blood vessels constrict, which basically hypoxia can actually be present with pale, cool, clammy, and increased heart rate. So the autonomic nervous system actually causes the heart rate to increase, but because you're going through hypoxemia, this actually presents as pale because your body is going through a mechanism to protect itself. So it shuts down all the sphincters and the capillaries that are in your peripheries. So key thing is you're gonna have cool skin, pale, and you're gonna have an increase in heart rate. And basically that's a drawing on how it actually reacts to it. So far, do you guys have any questions?
No, sir.
Okay. So oxygen content and ambient air. Yeah, one thing is that review all the aerobic metabolism components. Okay, so basically this is what we need to have intact for perfusion to occur, or good perfusion to occur. Oxygen content and ambient air. So you have oxygen within regular air that you're breathing in and out. Patency of the airway, that the airway is actually open. Minute ventilations, that your ventilatory rate is adequate and that your tidal volume is adequate. So we know that adequate respiratory rate in an adult, it's 12 to 20. So if you're at 16, you're okay. If you're at 8, then we have to worry about you. And not only that, if you're breathing fast, let's say at a hyperventilatory rate at say 28, your tidal volume is not going to be there because your heart, your lungs are, inflating and deflating so fast that they don't have enough time to deflate or inflate properly. So then your oxygen level is going to be kind of low. Now you have alveolar ventilation too, where you actually have the ventilatory rate occurring too in the tidal volume. It actually causes oxygen exchange between the alveoli and the capillary. Oh, I can see the first one. Perfusion and pulmonary capillaries. You have venous volume and right ventricular pump function that work correctly. In the gas exchange between the capillaries and the alveoli, content of blood, red blood cells have to be there with hemoglobin, and plasma has to also be there. Cardiac output and determinants, heart rate, preload, stroke volume, myocardial contractility, and afterload. So what is heart rate?
Isn't that the amount of beats per minute?
Yeah, it's basically the amount of beats per minute that you have. And what is the normal heart rate of a normal adult?
60 to 80.
60 to 100.
Oh,
80 being the medium. Okay. So preload, what's preload defined as?
Wasn't
That's the
that
amount
the
of,
blood that was in the heart?
yeah, basically it's the amount of blood that's coming back into the heart. What is stroke volume? The amount of blood that's going out of the heart. Okay. Myocardial contractility, the force that the ventricles have to squeeze that blood out. And what is afterload? Is the amount of blood that's actually gotten out of the heart itself. Okay. Now, stroke volume is defined by heart rate and by the heart rate also. So systemic vascular resistance, you have sympathetic nervous system stimulation and parasympathetic nervous stimulation. You have gas exchange between the capillaries and the cells also. And I think we're done with this. Do you guys have any questions?
No, sir.
No?
no, sir.
Okay. So what we're gonna do is tomorrow we're gonna review some of this stuff and then go over the new material. But right now we just finished, and next week I need to review all this stuff so we can get you prepared for the test next week. And the test is gonna be on Friday. So we have the whole week to review.
Nice, sir.
Okay? Anybody, any comments?
No, sir.
No,
Kayla, you're quiet. What's going on?
No, sir. I'm paying attention.
Well, yeah, but that's not what I said. I said you're quiet.
No, sir. I just slept really late. This week has been tiring.
Okay. Well, rest up, and I'll see you guys tomorrow then.
Goodbye, sir. Have a good afternoon.
You too.
Sir.
Yourselves.
Bye, sir.
Bye. Take care. Bye.